what this attendance shows something that we know as a fact in our lives. There is nothing that can beat a lunch session. So, well, we'll just have to make do with whoever are here. It's tough. No speaker can compete versus the sound of and the smell of lovely food. So we'll, as I said, there's a slight change. Dr. Amar has to go for another session. So we'll just start with imaging in strabismus surgery, and then we'll move on to the other topics.
Good afternoon, respected chair and all the colleagues here. So I'll be presenting imaging in strabismus surgery. I do not have any financial disclosures. So why imaging is essential? So it's basically for two indications. We want to understand the anatomical details, or we want some practical information which can be useful for surgeries. So for these reasons, we have few modalities which include CT scanner, MRI, or which can be considered orbital imaging, and there is one more section called local imaging, which includes anti-segment OCT and UBM. In clinics, we need imaging for these are the challenging situations where we need, that is resurgery, muscle slippage, ocular coat ectasia, or any other conditions. So in these cases, when you want to do CT scan or MRI, you'll be able to see the belly details, but you won't be able to tell where exactly muscle is inserting on the sclera. That's where the AIOS2S comes into rescue, and of course the UBM is also there. UBM and AIOS2S can be considered as a local imaging modality. So the uniqueness about these local imaging modalities is like they are cross-sectional imaging, and AIOS2S is a non-contact one, UBM is a contact one. And in UBM you are going to get only one scan. By using AIOS2S you can get 10 more scans or even 15 scans depending on how you are setting up the data. And these imaging will be done by the surgeon himself or herself, and they are cost effective. Unlike CT scan or MRI, they are very quick. So this is how we are going to image the extraocular muscles using AIOS2S. You can see here in the first image, with good abduction you can see the medial rectus muscle, with good adduction you can see the lateral rectus muscle, with good elevation you can see inferior rectus, and with good depression you can see the superior rectus muscle. So how to identify these muscles? See, these are the features we have described. So this is a lateral rectus muscle which we have captured. So we want to follow some of the fixed findings which can be replicated when you are identifying operated muscles. So this ocular coat is very well defined. It's convex, it doesn't have any surface bumpiness, it is not irregular, it's not having any scar. So ocular coat contour should be smooth. That is the first factor to identify it is an unoperated muscle. Second is, what is the depth of the hyperreflective layer? It is somewhere between 40 to 50% depth from the surface layer. So that's how the hyperreflective layer should be visible from the surface. If it is too deep, too superficial, probably that is not muscle. So intensity should be, it should be dark, but it should be having some internal noise because this is tendon. As you move posteriorly, that will be more dark because it's a pure belly. And the fourth factor should be, it should be continuous, because in some cases of operated eyes, you can see subconjunctival spaces which can confuse as a muscle, but whenever you want to define as a muscle, it should be continuously visible hyperreflective layer in an eye, and it should be around 40 to 50% depth from the surface layer. So how to scan this one? So whenever you are scanning, this is a Cassia machine, Cassia 2 short source anti-segment OCT. We should consider this plus safe configuration because it has a lengthwise and the widthwise scanning. So this is for medial rectus muscle, that is for lateral rectus muscle. This is again lengthwise, and this is the widthwise scanning. So this is how we are going to combine both the vertical and horizontal scanning. So this is the lengthwise, which is going to tell the insertion, and what is the longitudinal extension of the muscle. And this is a cross sectional. What is the width of the muscle? It could be 8 mm, 9 mm, 10 mm. This becomes useful in researches. I will tell subsequently. So how can we differentiate what is the tendon, where is the belly? So this is MR, again the 4 rectus muscle. As I said previously, the hyperreflective layer is going to have some internal noise which is tendon. Approximately you can say that probably belly has begun here, and this is more confident that this is belly. So the same thing applies to all the rectus muscles. So how much maximum muscle you can see? With good adduction you can see up to 9 mm of medial rectus muscle, up to 10 to 11 mm of lateral rectus muscle, and somewhere between 3 to 6 mm or 3 to 5 mm of superior rectus and inferior rectus muscle. So this is being said, we need to use this tool for some clinical purpose, and I want to tell one by one. So how to identify a recessed medial rectus muscle? So you saw the 4 criteria were there in the previous slides. So again we need to apply these 4 slides factors. If you see ocular coat contour, this is not smooth. There is a normal contour here, again sudden it is becoming thin here, that means muscle is missing. Hyperreflective layer, I won't see any muscle hyperreflective layer here, it is starting from here. Intensity, again it is initial portion. Continuity, I am seeing continues from here. So as we know anatomically, the sclera is going to be thinnest just before, just beneath the insertion. So this is the original insertion. Muscle has been sent posteriorly. So that's how you are going to identify the recessed muscle. So again, this is the medial rectus muscle. You can see, as I said, ocular cord contour is disturbed. It is bumpy. So that indicates that probably it was an operated eye. That is the first factor. Hyperreflective layer, again, if you see, the ocular coat is thick. In the previous case, it was thin. The muscle was sent back. Here, probably the muscle is there, but it is quite thick. Why? Because tendon has been resected and it is the belly. And we can see hyperreflective layer, approximately 50% of continuously visible. So it is a resected muscle. This is the lateral rectus muscle. Again, we are not able to see hyperreflective layer till here. So this is a probably original insertion and muscle has been sent back. This is a recessed lateral rectus muscle. So these are the side by side images of the one patient. You can see this is a right eye lateral rectus, that is a left eye lateral rectus. You can see all the four factors are satisfied here. We can see a continuously visible muscle, but again this is the original insertion and I am not seeing any muscle. Muscle is here. So if you measure from here till here, that is your amount of resection which has been done previously. So for lateral rectus resection, again the coat is becoming thick and you can see that there is no tendon here. It is a completely dark thick belly which is there in the original position. So this is again the resected lateral rectus muscle. Just compare with the left eye. You can see that that is a normal lateral rectus which has not been operated. This is the tendon which is less dark and the belly more dark. Here you can see this is more dark. So obviously this is a belly, tendon has been resected. So this is how we can identify which muscle has been operated or not. That is first thing, whether it's a resection and we can quantify the amount of resection as well. So this was first paper because in Indian scenarios we lose patients' data frequently. So I tested it in patients with lost details. We don't know which surgery has been done previously, whether they had ESO or EXO, and we found that AIOS2S025 is able to give the details, which could be 1 or 2 millimeter here and there, but getting information is important. Other clinical scenarios like muscle slippage, and of course this bleeding is because of preoperative FDD, force reduction testing. We did MRI, we can see that there is some orbital medial fracture, there is a discontinuity of the muscle, but I am not able to say where exactly the muscle is. I did OCT, you can see that it is quite superficial in the subconjunctival plane and there is a muscle here which is around 11.4 mm and I explored. We are able to see the ciliary vessel and on post-op day 1 we have ortho or slight mild ESO, 4 prisms. So that's how we are going to influence, because by doing transposition of superrectus and infractus you won't be able to give the adduction, but by advancing and finding the MR you will be giving the functional, which is physiological ocular movement. So this is one more post-traumatic. You can see lid notching also. He has injured his infractus. So and there is a hypertropia here. So again the CT scan will not be able to, or the MRI will not be able to give where the muscle is on the sclera. He is lacking infraduction, which is very bad. So we did OCT. We can see the muscle here, which is around 6.6 mm from the angle, and I placated and advanced the infractus muscle and I recessed the suprarectus muscle. At the end of 1 year he is maintaining orthophoria and of course he has a lid notch which is not bothered. Most importantly, we give the introduction, that is very important. Post surgery, this is one more interesting case where that's why I said we need to scan lengthwise and the widthwise. So if I scan the superior part, I can see the muscle is here, probably it was original insertion was here and it has been recessed. I can see here continuously, but here I am not able to see. And if I correlate intraoperatively, so approximately the muscle width corresponds to the corneal diameter, right? So only superior suture was intact and inferior suture got slipped. So that's how the inferior portion has slipped. That's why patient went for consecutive exo. And these are other conditions where, like in staphyloma, our sensory exos will develop and patients demand cosmetic surgery in those cases. And we don't know whether the muscle is incasted within the staphylomatous area or it is quite posterior. In those cases, we found that it lies beneath the staphylomatous area and we don't need to puncture here, go through the pharyngeal route, recess the muscle whenever possible. And one more condition is like in one patient, somebody had a complication. This is the operated SFL. You can see this is a haptic here, SFL haptic here, and MR is quite anterior here. So they were trying to do the MR plication, they injured the haptic and IOL went into the vitreous. So in those cases also we can identify and trace the haptic and we can just be cautious, right? So we don't want to injure the haptic. So to summarize, we can use AIOS2S025 in resurgeries, traumatic and surgical muscle slippage, ocular cord ectasia, or in other clinical conditions where it is challenging to do the surgery. So this was the second surgery where I did 1104 muscles, including the normal and the operated. We published that one. The third one was purely dedicated to the slipped muscles, which we published. And there's something called multimodal because we want to combine both the image together. So this is one scenario. So a patient had infractus injury in the right eye, the right eye hypertropia. This is the left eye control eye, and this is a CT scan. We do frequently, we don't do, but people in India frequently do CT scan as the first modality because it's a traumatic case. They don't go for MRI imaging because they are not looking for the muscle. In the left eye, as a control, you can see this is a belly which has gradual transition as a tendon and it's getting inserted onto the sclera. It is not stretched. On the contrary, you can see the anterior tendon is stretched here and there is a bulging of the belly because probably muscle is cut here, so that's why it has gone posteriorly. So similarly, if you see in the coronal sections, so the anterior tendon is thin here, the contralateral, the other eye, infectus belly in the anterior portion is quite normal configuration. If you see posteriorly along the orbital apex here, you can see the corresponding belly bulging. So in those cases, again, you are not sure where the muscle is, but if you do OCT, you can see the muscle. So here, what I am saying is, probably the rectus muscle tendon is torn here. That's why it is acting as a relaxing myotomy. The muscle has been pulled back. So that's why I am able to see the CT scan. But I won't be getting any insertion related because I need to open the conjunctiva here. I need to operate on this part, not on this part. So that's how you can use the CT scan, MRI plus AIOS2 knowledge just to create a story. That's how you can identify. So this patient was operated. You can see this is a fibrotic area which is avascular. This is vascular area. We shape the muscle margin and we placate the muscle. So this is multimodal imaging where we want to combine CT scan, MRI findings along with AIOS2 findings.
Can you sum up, please?
Yes, ma'am. So these are limitations. When there is a scar, you won't be able to see, and it's again a evolving tool. So in strabismus subspecialty, we can use AIOS2 for different conditions, including resurgery, muscle slippage, and other challenging scenarios. Thank you.
Thank you, Dr. Amar. Any quick question, because Dr. Amar will actually be leaving, so if there's a quick question we can take, or thank you.
Thank you, sir. Yes.
Yeah.
Are you able to do you bill the insurance or the patient for this, or how does it work with the billing?
So we work in a government hospital,
hospital,
where
okay.
billing
Billing.
is not a major concern for us. So
Yes,
that
sir.
is why. But I guess, I mean, if it's an investigation, just like you'll order an imaging, you would appropriately bill. But that's not something which we,
Yes, sir.
fortunately or otherwise, have to worry.
I work in a private institute, but most of our patients are uninsured, so they pay for it.
Thank you.
Thank you, Amar. So we'll now go to the next speaker.
Good. So I'm going to invite Dr. Srijana Adhikari to give her talk on ocular allergies in children. Dr. Srijana is a consultant at Tilganga Eye Hospital in Kathmandu, Nepal. She has trained in Storm Eye Institute in South Carolina. She has done a fellowship in pediatric ophthalmology from there, and she has been a consultant in this hospital for several years.
Thank you so much, Dr. Sumita and organizing team for this invitation. So I'm talking about the managing ocular allergies in children. So what is ocular allergy? It's basically an inflammations of the conjunctiva, mucous membrane lining the anterior sclera, inner eyelid surfaces in response to any allergens, either persistent or transient allergens. So around 20% of the world populations are impacted by some kind of allergies, and making it the most commonly encountered clinical conditions. It is basically a hypersensitivity reaction and results from various impacting factors, and genetic is one of the very important factor that plays a role in allergy. And on other factors, environmental factors like air pollution and atopy, of course, has some genetic relation, and others are pollen, inflammations, pet hairs, household particles, and the list goes on. There are mainly, how do we classify, because sometimes classification more important in allergy conditions is the finding out the etiology and management, but still we have to know what are the types of allergies that occurs. Like seasonal allergic conjunctivitis is one, perennial allergic conjunctivitis is others, and there is other list: VKC, atopic, AKC, and GPC, the giant papillary conjunctivitis. These are the basically types of conjunctivitis that occurs in the ocular surfaces. Now, what is acute allergic rhinoconjunctivitis? It is the most common form, and mostly it is divided into two types: seasonal and the perennial. Seasonal is mostly because of the pollens that is usually occurs around the spring season, and then the perennial because of the dust, mites, or fungal, and can occur throughout years or because of many other conditions. So Now, there is another classifications which has been proposed by the European Academy of Allergy and Clinical Immunological Classifications. You can all go through that, but this is mainly what is there in this classification is, one is IgE mediated ocular allergy, one is non-IgE mediated ocular allergy, and another is ocular non-allergic hypersensitivity. So they have classified in that way, and then the IgG, the VKC comes in the both the subgroups. Now, vernal VKC, which is the most common, most notorious, and very difficult for the ophthalmologists to deal with at times. And it is usually recurrent bilateral external ocular inflammations, mostly in warm, dry climates, immune mediated, associated with the atopy in many cases, and family history of atopy is also there in many cases. Asthma and eczema in infancy is usually the history, and onset usually from 3 to 5 years and resolves around puberty. That is what we usually classically know, but these days the allergy, the VKC, we in our daily practice see in younger children as well, and sometimes in infants also. And it is mostly seasonal, but throughout the year also it occurs. And then it has mainly 3 types, palpable, limbal, and the mixed types. The palpable VKC is mostly in the palpable region, as the name goes, and then the palpable sometimes it is just a small papillary reactions or papillary conjunctivitis, then can lead to the giant papillae also. And then limbal one, the limbal one has small honotanta dots, but sometimes it increased into some gelatinous like concentric rings in the cornea that can go in up to this severity. And then the complications occur sometimes like punctate epithelial erosions, shield ulcerations, which is very difficult and sometimes can lead to perforation as well. And then pseudogerontoxin we see, and then keratoconus, which is very, very important and associated with the VKC, and the keratoconus of course is very much increasing, at least in our practice it's increasing a lot, and maybe in other parts also. And refractive error, these are the conditions that is associated with VKC, and the steroid induced glaucoma and cataract is associated with the treatment with the VKC. And getting to the etiology of allergy, it's a very, very big challenge for everyone. So through better history, to correlate anything that is started and then associated with the allergy is very, very important to find out, and before any tests are done. But if we cannot do anything, then there are certain tests that are available which is not 100% but may help us, like skin prick or patch test can be done, or if it is not useful these tests, then we can go further into serum IgG, serum specific IgE measurements, and then the conjunctival allergen provocation test, which in my country also it is not done usually, but it's better to know that it's an allergic and the allergen is applied to the conjunctival mucosa and then find out. And also it is helpful in finding out the symptoms and respond to the therapy by this test. So these are some of the tests which may help us lead to etiology of the VKC. And then treatment of course is mild steroid or mast cell stabilizers, antihistamines, acetylcysteine, and this has the mucolytic properties and useful in the treatment of the plaque formations. And then comes the injections like betamethasone or triamcinolone injections in severe disease can be tried. There are immunomodulators which are quite popular these days, cyclosporin and tacrolimus, but many studies have shown that tacrolimus is better than the cyclosporin. So in my practice also, I prefer to use tacrolimus. And then the biological medications are also there. There are studies which shows that it's very good, the omalizumab, and then other like benralizumab, mepolizumab. These are some of the biological medications that is also coming up for these notorious allergic infections. And then another one is sublingual immunotherapy, subcutaneous immunotherapy. These are some of the things. And then there is another thing which is very much talked about is the vitamin A supplementation. So vitamin D supplementation. There are studies which have shown that the vitamin D, serum vitamin D level is reduced in children with the VKC. So we don't, in practice, we don't give vitamin D supplementations, or we in practice also we don't send the children for vitamin D label, but this is something maybe we can think of, because there are many studies coming up that has an association between the vitamin D and the allergic conjunctivitis. And contact lenses is another option. Contact lenses as a therapeutic use, and mostly in those cases where contact lens users and the VKC can also opt for the contact lenses. And then another use of contact lenses VKC is in cases of the Schilt ulcer or giant papillary conjunctivitis. Now comes the surgical. The debridement can be done, superficial keratectomy, and there is excimer laser phototherapeutic keratectomy, amniotic membrane transplantation may be required in the severe sealed ulcer. So these are the, we go to the surgical options only in a very severe cases. So these are, thank you so much for your attention for this quick update on the allergic conjunctivitis.
Thank you, Shrejna. Any
comments on, yeah,
a quick comment so that
Dr. Arif?
Yeah, are you, for the tacrolimus, are you using an ophthalmic preparation or the skin preparation?
Yes, this is a very good question. I'm using in my country as a skin preparation, because we don't have ophthalmic preparations by the government distributors. If we have to use, then we can use from, we bring from the India by other
Are you putting
procedures.
it directly on the eye or just on the eyelid skin?
Directly in the eye, but not exactly directly in the lower eyelid. Just apply, we ask the parents to apply a grain, or like a size of a grain, rice grain, to put on the lower eyelid, small amount, and it's stinging, and I think the ophthalmic one is also very much stinging, but it works very good.
it's
Works
getting
very
better.
good.
Yeah, initially the initial preparations were stinging, but now they are much better and fairly well tolerated. You put it in the inferior fornix, so you the ophthalmic one, you in the inferior fornix, and you ask the child to close the eye for a little while so that it remains and diffuses, and after that it is generally better.
Yes, and counseling is very, very important. I have found that if you properly counsel, already prepare the parents about these burning sensations and all this, it works very well.
And it's better always to start, I mean, initially have the aggressive intervention so that the congestion, the itching and all comes down, and then you start tacrolimus for a long time. And obviously it would be better, a little better from the reaction point of view, that you have something covering it. I mean, so you can even have artificial tears before you put the tacrolimus, so that it's a little more comfortable.
Yes. Artificial tear, after putting the ointment, you ask the parents to put the artificial tear along with that, just after 2-3 minutes, then it helps a lot.
And just on a note of caution, please teach the parents about the side effects of steroids, because steroids do give very, very immediate relief.
Yes.
And chances of on and off use, which lead to other problems, is far more common. So I think as doctors we should take responsibility and probably advise the parents. And second, please do refractions in these children, because a lot of them do have high astigmatism and symptomatic. They may come to you 4 times in a year, but at least once in a year you should repeat the refraction.
Regarding that steroid part, instead of fluoromethalone, the lotiprenolol would be better for pediatric age group.
Yes,
they don't have that penetration.
Sure, penetrations are less,
Penetrations,
but then no
but
steroid is safe.
Yes.
Yeah,
But definitely you can continue lotiprenolol for a little longer period of time than fluoromethalone or even Dexa,
yeah,
right?
For tacrolimus, it starts taking the actions after the 3 to 4 weeks.
For at least, yes.
At least
So
4. So
initially
before
we should
that,
start from twice a day.
Yeah.
Then we can start with at bedtime.
Once
or
a
you
day.
can just start with some like ketorolac or something like that for 2 weeks. Then you can start the tacrolimus. Then it works. We use that way.
Okay, thank you, Dr. Shrejna. We will now move on to pediatric optic neuritis. Dr. Sangeeta Khanna, she's a professor at the Kellogg's Eye Center, University of Michigan, Ann Arbor, and she's a very avid neuro-ophthalmologist. And we are of course grateful for her that she travels for the AIOS very frequently to India. It's always a pleasure listening to her.
Thank you, Rohit, for the introduction. Thank you to the organizers for inviting me. I see both children and adults for neuro-ophthalmology problems. So today we'll focus on pediatric optic neuritis. I have no financial disclosures. How does a child present when they have optic neuritis? So a subacute vision loss, acute or subacute, a unilateral or bilateral, and the children may or may not complain of pain. Some will say headache, and it can be bilaterals, and the fundus may be normal. So APD will only be present if it's unilateral. So that's to be remembered, since you may not have disc edema. And if you do an MRI, which you should if you suspect optic neuritis, you expect to see optic nerve enhancement, which will be seen on T1 fat saturated with contrast. But remember that the sensitivity is about 80%. So if you're suspecting optic neuritis, even if it's reported as normal, re-evaluate yourself, or do not exclude optic neuritis just because MRI was reported negative. The etiology uncommonly it's infectious, like TB in India particularly, or sphenoid sinusitis because of its association in the anatomical association with the optic nerve. But more commonly it is inflammatory demyelinating optic neuritis, which happens post-infectious, post-viral infection after 4 weeks post-vaccination, or it can be part of a neuroinflammatory syndrome such as multiple sclerosis, NMO, MOG. This is from the paper on update on pediatric optic neuritis. It shows the MRI orbit findings. In the first panel is MS, a 12-year-old with multiple sclerosis. You can compare the right and left optic nerves, and you'll see at the short segment of it's bright on this post contrast, and then in the B is a longer segment on the left with the optic nerve sheath is also kind of inflamed, so it's shaggy. That's the MOG disease. And in a neuromyelitis optica in panel C, that doesn't have perineuritis, but it's long segment. So just to be aware how different things look. So just a review of what is aquaporin 4 IgG or NMO antibody. This is a self-surface antigen on the astrocytes, and antibodies form against this. So these are tested in serum, and it's by a cell-based assay. And they can have other symptoms because these aquaporin 4 receptors are found in certain areas of the brain, so they can have intractable vomiting or hiccups along with optic neuritis or myelitis. MOG-associated disease is present. Again, the MOG is on the oligodendrocytes. Here you can see, and that they produce the myelin. And again, these are antibodies tested in the serum, not CSF. So you just do serum studies, cell-based assay, and you want to use a cutoff for this. A low titer does not have as much specificity. So testing is serum cell-based assay, and live cell-based methodologies have less false positives than fixed cell-based assay. And the fixed cell-based assays are what are used in India mostly. Is that correct? Yeah. And this study showed that they perform well compared to live cell-based assay, but just be aware of false positives in MOG, so use a higher titer. We usually use 1 in 40 or higher, maybe even 1 in 100. And then knowing, if you look at the North American experience, the Pediatric Optic Neuritis Prospective Outcomes Study recruited all incomers with acute optic neuritis, and they were 44 children recruited, and the incidence is kind of low, therefore the smaller number. And what they found was that about 40% was isolated optic neuritis. MOG disease was the next most common cause, about 30%. Multiple sclerosis was less common, and neuromyelitis the optica was only 1 patient. and 7% presented with ADEM in addition to optic neuritis. Only 3 out of these 44 patients, as they were followed for 2 years, developed recurrence, and all of these were related to multiple sclerosis patients. They were not MOG disease, and this is ADEM, where you get these bigger white hyperintensities rather than MS. There is North India literature which in 2024, which had a similar 67% isolated optic neuritis. MOGAD was about 27%. So it's a similar incidence in India. Multiple sclerosis was less and a little bit more aquaporin 4 than North America, and ADEM was about the same. There was a South Indian study, a retrospective, but they did not do MOG and NMO at that time. So all we can take from here is that multiple sclerosis was not common in these patients. So they can mostly present with isolated optic neuritis in children. And let's move on to the clinical features. Many will have disc edema, unlike adults. And they will present with quite severe vision loss. Many are unilateral, but if in a younger patient under 10, it can be bilateral disease. So let's look at this case of a 6-year-old female who reports decline in vision with pain in the left eye, otherwise healthy, and the count fingers vision in that eye. So quite a drastic vision loss, APD, mild disc edema, as you can see here. So suspected left optic neuritis. So what should I do now? So we want to do MRI orbit and brain. You want to see what's the length of the orbit, optic nerve involvement, and you want to see is there ADEM, is there white matter lesions. You also want to do MOG antibody and the aquaporin 4 antibody, and if need be, a pediatric neurology evaluation. This is her MRI, which shows long length with perineural enhancement. So she indeed had MOG disease, and you can see we get a titer. It's a 1 in 1,000. So how should we treat this? This is about lumbar puncture. I leave it to the neurologist to decide if they need a lumbar puncture. They don't always do, but I think in children they tend to do that. In lumbar puncture, I just want to know, there's one caution that CSF opening pressure may be high, so that doesn't change your diagnosis. It doesn't become IIH just because there is disc edema and high pressure. So the treatment, we don't have an optic neuritis treatment trial for children, but we use this information to guide us. And this showed us that don't use 1 milligram per kilogram dose of oral steroids. That causes higher recurrence. So go instead with IV methylprednisone. So in pediatric optic neuritis, we give 3 to 5 day course of IV methylprednisone. The dose is 20 to 30 milligram per kilogram per day, maximum of 1 gram per day. And then we follow it with bioprednisone taper. We are giving oral bioequivalent dose, like 1250 of oral prednisone to our adults and occasionally to older children. That is less expensive, and I don't think it's used here, but worth considering if patients are financially constrained. And compliance with that oral dose has been documented to be very good. So for MOG positive, as this patient, what should we do? We treat with the IV methylprednisone. If it's severe vision loss and no response after 3 days or insufficient response after 5 days, usually we go to IVIG. This is the neurologist, but you will guide that, because we don't want to delay. If you do it within 2 weeks of onset, there's much better outcome. And or some neurologists prefer plasma exchange instead, but both are the options, IVIG being preferred. And then you start the steroid taper. Make sure you don't keep the patients on steroids, especially children, for a long time. Usually start tapering in about 1 to 2 weeks and maximum of 4 weeks. Not all children need MOG prevention. It's only needed if there is a recurrence after the first attack. You don't need to give. So I'll move on to just telling you that children with MOGAD often have a monophasic course. So no need to put them on preventative right away. And one last with prognosis for MS in children, in the adults it was like 75% chance if you have a brain lesion, but in children we don't have that data, but we do know if it's an older child with white matter lesion, they can have a higher risk of developing MS. I think visual prognosis is very good. Most children, though they may present with severe vision loss, they improve, so you can advise the parents accordingly. Remember, there are mimickers. Leber's hereditary optic neuropathy. This does not respond to steroids. There is no enhancement. Infiltrative disease, if there's leukemia, the MRI can look like optic neuritis. Neuroretinitis has a large amount of subfoveal fluid and a macular star. Fulminant IIH will have bilateral disc edema with hemorrhage that can look like MOG, but there's no enhancement. And the CSF is high pressure, but no cell or protein. Thank you so much.
Thank you. Thank you, Sangeeta. Any quick comments before we go on to the next question? Comments or questions? Yep.
You can use the mask.
The mic.
The neuroimaging part you mentioned, even if the MRI with contrast is looking normal, you should not exclude it. So if you compare with the adult optic neuritis and pediatric optic neuritis, is there any difference for the neuroimaging?
Yeah, the MOG disease is more common in children, and in MOG associated disease you'll see more positives. It should be positive, the enhancement. So it's only in the post-infectious optic neuritis, a milder form, that it may look normal. Sometimes a review by yourself or a neuroradiologist will pick up. But if you go just by the report, don't dismiss it.
Okay.
Thank you.
And the oral bioequivalence, so the person would have to eat a fair amount of tablets?
Yes, we give 50 milligram tablet. We give 25 50 milligram tablets. And the study from Canada showed very good compliance. And we routinely do that. Our neurology and us, we routinely do not send them to the hospital for infusions anymore. And they are tolerating. I've only had one patient who accidentally took 25 of something else, which was on her bedside.
Okay.
But other than that, everybody's been good.
Okay. Sure. 25 tablets can be quite daunting, no?
Yes.
Yeah. I just want to ask one question. Like, we have a 6-year-old with optic dispeller, and obviously MOG and NMO all are negative, and you start suspecting maybe some kind of a mitochondrial mutation in this child. So when do you consider giving IDBNON in these patients?
Yeah. I think for us, it's when if you have excluded optic neuritis and if it's genetically positive, if you found a mutation. We don't do presumptively. But I assume like the main mitochondrial panel is easy to test, but the nuclear panel is harder to test. So that's our usual take. But
yeah, I guess, I mean, first, it's not so easy, just like for steroids, it's not easy to take that much. We have, I think, only 40 milligram tablets available for IDBNON. Okay, so
really? For
yeah,
the 900?
yes, for the 900 milligrams. So again, he has to skip his breakfast and have those.
That's right.
45
There you
milligrams.
go.
Yeah.
You have proof of concept that people can take a lot of tablets.
Yeah, so that's fair enough, but then obviously you're not even so sure how much impact it's going to have. I mean, it needs to be treated for a fairly long period of time for it. So that is why it would be better if you use that in the mutation positives rather than.
What about these coenzymes? What are used instead of IDB-non? I mean, because they affect the mitochondrial chain.
Yeah, I think
So-
that's anybody's guess, but I don't think we have data to support the use. But if there's no harm, I think.
Again, the cost comes into picture. A large.
Yeah, they are quite expensive.
They
no
are
doubt.
Yeah,
expensive,
we are, if your question is, are you using, or is any of, we are not, and most of my colleagues are not.
Thank you.
Thank you, Sangeeta. We'll go on to Dr. Sumita Agarkar. She's from Shankar Nethralaya, Chennai, and a master in pediatric ophthalmology, particularly pediatric cataract. It will be a pleasure to see her talk on management of congenital cataract in the 21st century.
Thank you for that generous introduction. I wish it was true. So I'm going to talk about pediatric cataract. So it's a rare but important cause of childhood blindness and can be responsible for 5 to 20% of the childhood pediatric blindness worldwide. Of course, the incidence is much higher in economically poor countries, and definitely anywhere between 1.8 to 3.6 per 10,000 live births. So, which is a huge burden in terms of morbidity, economic loss, and social burden. So, these are the various etiological factors, and they are all self-explanatory, and you can see in a pediatric clinic a whole spectrum of children presenting with cataracts in different ways, starting with lenticonus with posterior capsular dehiscence to steroid-induced cataract here. In between there are several with trauma, both penetrating and congenital cataracts, etc. So preoperative evaluation we should attempt to record visual acuity, because better starting visual acuity often leads to better prognosis. So every attempt should be made to record what is the preoperative visual acuity. Detailed anterior and posterior segment examination on slit lamp helps in very young children. You can use the indirect ophthalmoscope to give you some magnification, and you can see. If possible, you should check intraocular pressure. Otherwise, it is possible to do all of this before starting surgery under anesthesia. Of course, digital biometry or lens power calculation if planning. Ultrasound B scan if there is no view of fundus. And of late, there have been several publications on using UBM to give more information on posterior capsule, zonular status, and vitreous state, and if there is any posterior capsular dehiscence in very young children, sometimes UBM is more useful. Again, AIOS2S025-GP1 has been very useful in certain situations like measurement of the bag size. There is a recent publication from PGI Chandigarh about how they use the information of measuring the bag size to decide IOLs and decide whether possible to put an IOL in a child who has slightly smaller anterior segment. So, and also it helps you in the interaction, it also shows you how the vitreous is interacting with posterior capsule. Sometimes it has helped in intraoperative decision making, and that's a very nice article by Dr. Sukhija and his colleagues. So management, again, if there are very small and very peripheral opacities, you can probably observe, give appropriate glasses, but anything more than that, probably they all need surgery. And importance of early surgery. So a cataract which looks like this with a peripheral opacity need not really do surgery, and this patient can be very well managed with glasses. So these are the surgical challenges. You have sometimes facility of anesthesia itself is a little dodgy. Sometimes I'm talking more in terms of our country here. Sometimes small eyes with coexisting morbidities, a very elastic capsule. Need to deal with posterior capsule and vitreous at the time of surgery means you should have a really good vitrectomy machine, and reliable DBR and availability of the library of lenses, management of aphakia and follow-up. These are all not just surgical but post-surgical challenges also. So these are the steps of surgery in children, and I would think management of the anterior capsule is really the most key step, and there has been instrumentation available in terms of Zepto laser or vitrector sometimes, but still manual CCC probably has the safest edge, which is least likely to extend. Dyes and cohesive OVDs have really made anterior capsular management really easy. So here I'm just showing a small video where this capsule in 10 years back would have been very challenging, but because of the presence and easy availability of the dyes, you can really see that it has made all the difference to correctly size the capsule, correctly size the anterior axis, as well as the other video is of a fibrotic capsule where you may have to think on your feet, where you have to actually use MVR blade to make the initial entry, and then you can use scissors. If the capsule is not fibrotic, you can use a Utrata or a microcapsular forceps to make that rhexis. And as I said, both these situations, you can see the OVDs and dyes both make a whole lot of difference, and that has really changed the practice for us compared to surgeons who were operating earlier. Cortical aspiration, mostly they are soft cataracts and you can aspirate them. Maintaining anterior chamber depth prevents the AC collapse, but occasional child may have a very dense nucleus, and here probably you will have to, if you see a densely formed nucleus like this, this is a 8-month-old baby, but you can see it's almost like a soft adult nucleus, and I had to actually use a phaco probe because of its wider bore, and still I struggled with this because some of these you may be surprised by the density of the nucleus. So you have to be prepared and keep your phaco probe tuned and ready if you need to use it. Some difficult situations, traumas are always a difficult situation. So is the persistent foveal vasculature or PHPV, where you can have just a partially absorbed cataract with a dense vascular membrane and no dilatation, and sometimes despite using synecholysis, these patients may not dilate and they have often a tendency to bleed on table, so you may have to use cautery to a 23 gauge cautery to really. So despite stretching using hooks, I am not able to get a good dilatation to really and if you leave it with the membrane or really don't do a little half-hearted approach, then you're likely to develop again. The membrane will grow again and you will not serve the purpose of surgery. So I have done a little bit of a pupilloplasty using a vitrector, and that really dilates the pupil, and then it's only a matter of patiently cauterizing every blood vessel which is going across, and using scissors as well as cautery in conjunction to fashion some kind of a visual axis which is clear of the cataract. And as you can see, it's just a membrane, it's not really, there is not much of lens cortical matter there, but you need to have this cautery. And of course, because she had a very stretched ciliary processes, I did not attempt to put an intraocular lens here. So posterior capsule management, again very important, because a beautifully done surgery can undo with PCO within a matter of few weeks or few months. So whether every child needs anterior vitrectomy, probably not. Children who are older than 6 or cooperative to allow you to check pressures in the OPD, probably you can leave anterior vitrectomy and just do PPC in them. Posterior optic capture also does away the need to do vitrectomy, and again there is enough evidence to show that it can help you to avoid vitrectomy, and you can just get away with PPC and have good clear visual axis months or years later after surgery. You can do a vitrectomy after IOL implantation also. Intraoperative integrated OCT has improved surgical techniques, and it has really been very useful if you have access to that kind of a microscope. It allows visualization in greater resolution and improves outcomes on the table decision making. So for people who don't have access to that microscope, you can still do a good PPC manually. And I will just tell you one thing, sometimes don't overinflate and use a retro illumination, and you can see the posterior capsule much better. And here, if if I had access to integrated OCT, it would have shown that there is thick attachment between the lens capsule and the vitrectomy, and I might have put the lens first and then done the vitrectomy. But so these are some. So then comes the management of aphakia. You have contact lenses, you have and IOLs as well as spectacles. So availability of foldable acrylic IOL has been really a game changer for a lot of us, and because it allows implantation through a very small incision and a very good chamber maintenance during surgery. There has been a significant decrease in postoperative inflammatory response and probably is the standard of care above 1 year of age. However, in younger children, even with IATS studies, it has not conclusively proved that it has IOL is superior over the aphakia, but anatomical parameters like axial length and corneal diameter play a role in decision making, and I think if you have adequate corneal diameter of at least 10 and axial length of 80, and appropriate surgical skill and ability to do follow-up, then you should probably think of IOL in infants. But apart from that, you probably have to, other factors like I have mentioned here, they should form a part of your decision making. Now, IOL formula, in perfect IOL formula is still a work in progress, and what I do is we calculate lens power calculation using two formulas and find a middle ground. We have done some work on Barrett's formula for children, and it has the prediction error was pretty much same as how it was for other standard formulas which we have used. Lens designs, again, this lens in the bag is lens in the back probably is something which looks future, where you can again do away with vitrectomy, and you can have a clear visual axis, and probably this is one way of avoiding the whole vitrectomy thing. EDOFs and multi-trifocals in children, very little evidence or long-term data available. Myopic shift happens even in children older than 10, so you have to be, they are moving targets and with unreliable biometry, and probably you should avoid the lenses till more evidence becomes available. Toric lenses can be considered as an option. There are at least 2 or 3 publications from India on the toric lenses, and this is my experience with 22 eyes. Of course, my average age of children in our series was around 10, and we were able to significantly decrease their astigmatism as well as improve the visual acuity significantly. So in selected cases, you can consider toric IOLs in slightly older children. However, when in doubt, aphakia is, I always maintain aphakia, a good aphakia is always better than messy pseudophakia. So follow-up is lifelong and relentless in children. New problems can arise despite well-done surgery. Follow-up must include visual acuity, refraction, IOP measurements, and retinal evaluations. And glaucoma and retinal detachments are vision-threatening late complications which require vigilance. Thank you very much for your attention.
Thank you, Sumita.
And yes, this is on request of Dr. Deepa. Please, if you have not registered,
right.
This is a nice conference coming up in Brisbane.
They have actually removed the slides, so. So yes. So a trip to Australia for the Australia. Yes. So talking of Australia, we have the next speaker from Melbourne, Dr. James Elder, and he has a lot of surgical experience in all aspects of pediatric ophthalmology and strabismus, including and particularly cataract, glaucoma, oculoplasty, and retinoblastoma. So we'll hear him talk about screening and prevention of ROP.
Thank you for inviting me to talk in this session. There's sort of a change of pace here, because this is more about hospital systems and protocols and things of that nature, rather than exactly what the ophthalmologist does. So we all know that ROP is a disease of retinal angiogenesis that's seen in some premature infants. Basically, you can think of it as a VEGF gradient that encourages the growth of blood vessels. And because when children are born premature, their vasculature is immature, we see this problem. Originally, we only recognised the end state of this with a totally detached and scarred retina, and it was some time before the vascular nature of this disorder was seen. very early on, the risk factors were identified. It used to be called the Boston disease when it was first identified in the US. And one of the things that stands out in the notes of the first patient identified as having retrolental fibroplasia is that they had constant oxygen and completely unmonitored. And so that tells us very much what one of the major risk factors are. So what are the risk factors for prematurity? The degree of prematurity is important. I'm not sure what everyone else's experience is at the moment, but I'm starting to see babies of 22 weeks gestation considered to be salvageable, and they have an incredibly high risk of retinopathy at prematurity. So there's this inverse relationship between gestational age and birth weight and the risk of ROP. Oxygen therapy, and particularly how it's administered early on and the dosages and the saturations that are aimed for a little later. Poor weight gain is another big risk factor. There are a whole lot of others that are not quite so relevant. Prevention, this is really where it broadens. It's a whole of health system thing, so it's avoid, minimise premature birth, and that's nothing to do with you or me. Optimise the fetus prior to delivery. Again, that's nothing to do with you or me, but incredibly important to what we do. And then optimise the care of the premature infant following preterm birth, and then again, that's not you or me. This cartoon goes over some of the things that you can do to look at prevent preterm birth. You know, things to do with family planning, antenatal care, the management of labour, to use tocolytics to delay premature labour, give steroids at that stage so to increase lung maturation, and I'll talk a little bit more about that. So there's a whole host of things here. Most of these are managed by obstetricians or public health and things like that, but they're incredibly important for what we do looking after ROP. Again, there's specific measures here that are just outlined. Corticosteroid deliveries during premature labour are very important to mature the lung, and the tocolytic agents just give those steroids time to work. There's a nice, a few years old paper that just summarises this thing, points of care, in the things that are really important in caring for a premature baby. Pain control, oxygen management, and this is really interesting. These are the target saturations that the neonatologist should be looking at certain periods after birth. And so not all premature children should be given 100% oxygen at birth. They should be managed with CPAP, and then given oxygen if they fail to meet those things. And those sorts of things of too much oxygen early on probably unleash a cascade of things that increases our risk of severe ROP. And there's the other factors that the neonatologists do with nutrition and temperature control, etc. We know from several large randomised trials that were done that what target saturations we should be aiming at once the child is in the nursery, and basically they're in the low 90s are very important. Screening, now the slide just as a principle of screening, we don't need to read it from front to back, but ROP ticks all the boxes. We have a captive audience, we understand the disease, it's acceptable to the population, and we have good treatments. And so the challenges, not so much is screening worthwhile, but how do we do that? And, we need a common language, which we have. We need guidelines and service provision, and these are whole of health system organisational things, that some of which are not necessarily under the control of an ophthalmologist. The common language is ICROP. ICROP 3 is what enables us to look at that photograph, and in a baby of 32 weeks post-gestational age that was born at 22 weeks plus 3 days, and last week the fundus looked pretty normal, tells us that that's AROP. That's the AROP that we see in countries where they're extremely premature babies rather than problems with oxygen toxicity, AROP, or sick baby AROP, as it were, where it often is more peripheral. And so we know that, I'm not going to go into details of that, but they're all the things that are covered in ICROP 3. I guess the things that are new and important there are related to regression and reactivation, particularly in the era of using VEGF inhibitors, which has become much, much more common. So guidelines, and this is guidelines for the ophthalmologist and the units where these are managed, and they need to be evidence-based, and all these things need to be maintained and kept up to date. There are a variety of different screening guidelines. Obviously, there's the American Academy of Ophthalmology and Pediatrics, and they should have regional variations. They can't be one size fit all. We shouldn't all use the American Academies because they're good, because they won't fit certain population groups. Now, I'm sorry if this one I've got here for retinopathy of prematurity for India is out of date. It's some years old, but you know, their cut-off for babies they look at was 2,000 grams or 34 weeks. Whereas in Australia and New Zealand, we've just revised our guidelines. Most units use 1,250 grams in 30 weeks. Some units a little bit larger. And a recent publication from Ethiopia has come up with what their recommendations are. So all of these are regionally and institutional specific. Guidelines need to cover a whole lot of different things that tell everyone what they need to do, because, as I said, it's a whole of system thing. If the neonatologist doesn't tell us to see a prem baby, they'll be missed and they might go blind. And so these guidelines need to cover everyone's responsibility to make sure that all of the right children are seen at the right time by the right person. And I'm just going to highlight some of the points, and this is and some of that is there as the responsibilities of the different teams. I'm just going to highlight some of the features from our Australian guidelines. So there are some evidence-based guidelines as to when to start screening, and we follow those. The method of examination, now that's pretty universal as to how that's done, but these days, obviously, a lot of wide-field digital photography is used, and we're very familiar with that in India. Important features here are pain control. Pain control is always important for a premature infant, and it's one of the things that gives a better outcome. So sucrose, topical anaesthesia. Infant monitoring to make sure that they're stable during the is not the responsibility of the ophthalmologist. Which children require treatments? Well, that's really covered in ICROP, type 1 and AROP. The timing of treatment needs to be specified in your policy. And this other thing of looking at the responsibilities of the different people involved in this care. So our guidelines clearly specify what are the responsibilities of the neonatal team, the ophthalmology team, and also more widely the organisation. The institution has to support this and fund these things and make sure there are appropriate people available. We have laser standards for the children that need laser and things like that. So, in conclusion, I'd like to say there needs to be a common purpose that's organisational-wide and indeed wider public health right to reduce the incidence of premature birth, provide optimal care for those children, enable screening that's timely and to those children that are high at risk, and ensure that the children that are at risk of visual loss, which are the children with type 1 and AROP, that they get care when they need it. I haven't said anything about follow-up here, but follow-up is obviously an important feature of this because these children are prone to other problems, refractive error and strabismus, as well as their retinal morbidity. And it really stresses that it's a whole of healthcare system input required to get the best outcome for these children in terms of prevention and screening. Thank you.
We will please keep your hold on to your questions. We'll finish all the speakers and then we'll have some time for discussion. So may I now request Dr. Rita to come and give her talk on retinoblastomas. Dr. Rita is associated with University of Indonesia National Central Hospital, and her main area of interest is retinoblastomas and pediatric ophthalmology in general.
Thank you, moderator. I would like to share with you what happened in the advancement of management of retinoblastoma so far. What we are doing differently in 2025. I have no financial to disclose. As we know that there is a shifting trend in retinoblastoma management. In the past few decades, there is a paradigm change in the treatment, shifting from enucleation and EBRT, external beam radiation therapy, to less aggressive modalities for eye to preserve the eye and the vision. So, and then in the past few years, there also a significant advancement in the diagnosis and treatment of RB toward the more personalized and effective care. So we have entering the era of precision medicine, which is focused toward the personalized treatment strategies through identification of biomarkers. We know that there is shifting from cellular-based or pathological risk factors to more molecular genetic-based marker as indicators for the diagnosis and prognostic marker. A recent study reported by Jesse from the Children's Hospital Los Angeles, they reported development of new platform DNA sequencing, RB sequence for kids to predict RB tumor severity. How it works? It is they take the aqueous hormone liquid biopsy and then run into the new platform sequence at the diagnosis. This is to predict two biogenetic prognosis markers, which is mix and amplification, which will predict the tumor aggressiveness, and the second markers is 6P gene to predict the recurrences, the potential recurrences of the tumor. So this is very useful, that can predict eyes that can respond to the therapy and be safe or likely fail to the treatment, require inoculation. So this is reducing the unnecessary treatment. But nevertheless, although this is a promising approaches, the ongoing validation is still required. The second point to note is there is significant trend toward targeted primary therapy with selective IAC and intravitreal chemotherapy. The goal is to increase the drug concentration in the tumor while minimizing the systemic side effect. Two approaches has been reported. One is IAC or OAC, selective intraarterial chemotherapy. We know that this procedure developed quite long time ago by Suzuki, the Japanese doctor, introduced the intraarterial melphalan delivered through microcatheter directly to the ophthalmic artery. So melphalan, topotecan, and carboplatin is multiple agents that commonly used, but nevertheless there are side effects. The predominantly is choroidal vascular toxicity, most common side effect, and the other less toxic, and the other is less side effects. And there has been many studies reported on the efficacy and safety of these procedure modalities, mostly reported retrospective study. Recently there is report that reported the success rate of super selective catheterization procedure that reported there is improvement over the time. There was a study reported by Koharian et al. From the New York group, retrospective cohort in 571 patients. They try to assess how routes of vascular access to ophthalmic artery have evolved over the time. The second question, how many patients have had complications from the procedure, and which combination of chemotherapy drugs should be used. The conclusion is quite promising. The overall rate of successful catheterization is almost 100% and has improved over 15 years. And catheterization related complications are rare, 0.6 in the recent cohort period. And there is a trend toward use of the triple chemotherapy, melphalan, topotecan, and carboplatin. But they suggested a stepwise algorithm to maximize direct vascular access is important for the successful procedure. The other methodology approaches is intravitreal chemotherapy. I think you already know about this. It is ideal for targeting vitreous diseases. Melphalan and topotecan is the most commonly used drugs. How is the efficacy? Quite high, 80 to 100% efficacy in response to the vitreous seeds. And recent study reported quite high 90 and 1 month follow-up with IV topotecan 30 microgram in 0.15 milliliter is effective against both refractory and recurrent vitreous seed after completion of intravitreous or IAC. And how about the safety? The melphalan dose 20 to 30 microgram reported the most side effect is retinal toxicity, especially for the deeper inherent pigmentation like in Asia population. How about topotecan? Topotecan considered as a safer cytotoxic agent. So what dose should we use? There are 2 studies. One is animal study, reported about 50 microgram in the animal model, which is about 100 microgram in a human equivalent dose. And then the recent study in human reported high dose IV topotecan 90 to 100 microgram is effective and safe therapy for recurrent retinoblastoma in conjunction with other therapy. Of course, this is not enough subject, and more subjects should be required to validate the result. The number 3 is development of novel treatment for oncolytic viruses and immunotherapy. This is an emerging therapy aimed to selectively target and destroy cancer cell while sparing healthy tissue, showing promising result for intraocular tumor, which is unresponsive to conventional treatment. There are 2 examples, which is oncolytic adenovirus therapy targeting the RB1 VCN01. I think yesterday there are a speaker reported this in one session. And then the other modalities is immunotherapy, GT2 ganglioside, but this is still in a limited translation before we apply it into the clinical practice. This is just to show which very busy table, but about the phase 1 VCN01 trial. You can read it in a publication in the references, but the result is promising that VCN02 is clinically effective in RB patient. The other results significantly reduce the number of vitreous seed, quite safety, well tolerated, and VCN replicated with RB tumors over time. But this is also have to be conducted in a more phase 2, and phase 4 before we apply it in a clinical practice. The point first is the trends to get more global collaboration in order to enhance care and research, international collaboration among treatment centers as here, facilitate the sharing data, accelerating the development, ensuring benefit patient. The following is the example of global collaboration study that has been contributed so far. So what is the despite the very advancements, but there is challenge and future direction in RB. Less progress, however, in management of advanced and extraocular or metastatic disease. This group of RB continues to have poor prognosis. And the other thing is shortage in access to the best treatment option in low, middle, and middle income country because of limited resources. So, and as a conclusion, what we are doing differently in 2020 2025, eye globe preservation treatment continue to advance rapidly. Several new approach, IAC and intravitreal being developed, making intraocular RB the most curable pediatric cancer in high-income country. But how is it in a low-different country? Challenges in implementing this approach, new approach in some low-income countries is still there due to limited facilities. The conclusion number 2 is less progress in the management of extraocular or metastatic RB, which therefore continues to, this group of RB still have a poor prognosis. Thank you.
Thank you for that excellent summary of the new treatments. May I now request Dr. Arif to talk on genetics, ocular genetics for the pediatric ophthalmologist. Dr. Arif is a senior consultant ophthalmologist at Cleveland Clinic, Abu Dhabi. Dr. Arif.
Thank you, Dr. Sumita. Thank you, Dr. Rohit, for having me as part of this symposium. It's my pleasure to be here and my pleasure to speak about this topic. So my time is limited, so I'm going to go through 3 scenarios that are applicable to pediatric ophthalmologists no matter where you practice if you're seeing any volume of patients. The first one is exemplified by this 4-month-old boy. He's the one of 4 siblings. Parents are not related, referred for nystagmus. We examine him. He has no iris. He has peripheral keratopathy. He has a lens opacity. There's no fovea. This, of course, is classic aniridia. Now, I'm a big fan of genetic testing, but I admit that most patients don't need genetic testing for medical management. However, there are exceptions, and I would say this is one of the exceptions where genetic testing is medically indicated. Not so much to see whether or not this child has a PAX6 mutation. Of course, PAX6 is the most common cause for classic aniridia. But to see whether or not this child, who is a sporadic case, has a deletion that's large enough not only to hit PAX6, but also the neighboring gene WT1. If that happened, then he has a predisposition for Wilms tumor of the kidney. And sure enough, when we do genetic analysis, he has a large deletion. It includes WT1, and he goes on to develop Wilms tumor of the kidney 1 year later. But because he was being followed closely, because we expected it to likely happen, it was able to be managed aggressively. This is an ideogram of chromosome 11. PAX6 sits there. The mutations in PAX6 cause classic aniridia. But the important point that all ophthalmologists and actually all medical specialists talk about is that it sits next to WT1. If you have a large new deletion, you can hit WT1 and have a risk for Wilms tumor. This is a classic contiguous gene syndrome. We really have to be aware of this as ophthalmologists because no one is as tuned to this as we are. Here's an infant girl with oculocutaneous albinism, referred because she had cataract surgery and she failed to wear her aphakic contact lens. Here she is. One eye, she's aphakic. The other eye, she has a mild lens opacity. She has albinism. We have the gene mutation. Genetic testing was done. But why did she have cataract? That's not part of albinism. And why does she have lack of iris? Any patient can get a new deletion, even if they already have a different genetic disease. And sure enough, when we do genetic analysis on this patient, who already had genetic testing for albinism but didn't have this test, we find there's a large deletion on 11p. And when we palpate the abdomen, there's a Wilms tumor that even an ophthalmologist can detect, unbelievably missed previously. So we really have to be aware of these kind of things. If we aren't, nobody else is going to pick these kind of things up. Most classic albinism is intragenic PAX6 mutation, so it's not associated with this risk, and it's hereditary. And this is the first concept I'd like to go through. Wagner syndrome and PAX6 mutation in general should be on our radar as pediatric ophthalmologists. The next scenario is exemplified by this child with corneal haze, who was sent to me for glaucoma surgery. Now, I don't have pictures of the corneas to show you, but I have pictures of the face. And because time is limited, I'm just going to tell you, these facial features are very coarse. And this patient has an undiagnosed mucopolysaccharidosis. patients with some forms of mucopolysaccharidosis come in with corneal haze. And again, we pediatric ophthalmologists are more tuned to this and able to pick it up earlier than anybody else. And why is that important? Some of these forms of mucopolysaccharidosis are amenable to treatment. And the earlier they're picked up, the more efficient the treatment. Here's another patient came in with corneal haze, referred for possible glaucoma. Can you see those facial features? It's an undiagnosed mucopolysaccharidosis. And another one referred with corneal haze, undiagnosed mucopolysaccharidosis. Now, if a child has severe mucopolysaccharidosis, nobody's going to miss that something is wrong. But there are a lot of attenuated forms out there where it's not so obvious. And here's where we come in and are able to detect these patients more easily than anyone else. Excuse me for showing an adult in this pediatric ophthalmology symposium, but I need to show you this case. He's a 33-year-old male referred with burning eyes. He's got short stature, hearing loss, sleep apnea, asthma, bilateral carpal tunnel syndrome, and he has mild corneal haze. He has an attenuated mucopolysaccharidosis that was missed for 33 years of his life because nobody put all of these things together. What's the big clue? The corneal haze. When you look at features of attenuated mucopolysaccharidosis, corneal clouding is way up there as one of the signs. Again, we as pediatric ophthalmologists able to pick this up and suspect it better than anyone else. Final scenario I'd like to share with you is exemplified by this 3-year-old girl referred for low vision, nystagmus, and abnormal head position. She has oculocutaneous albinism. You're a good pediatric ophthalmologist. You can pick this up pretty easily. However, we're not done. We have to ask some pointed questions. And we ask this patient, this family, about any bleeding tendencies, and she bleeds so easily. This patient has one of the most common syndromic forms of oculocutaneous albinism, Hermansky-Pudlak syndrome. Now, depending on where you practice, this may or may not be common. In my patient population, it underlies a surprising number of patients with oculocutaneous albinism, important to pick up because these patients are prone, depending on the type, to fibrosis in organs such as the lung and the liver, and you want to pick these up patients early for anticipatory management. They're all over the world, though. Depending on where you practice, they're more common than others. Here's another girl referred for low vision. No problem in diagnosing her with oculocutaneous albinism. And sure enough, the pointed question, she's easily bruised, genetic testing, she's got Hermansky-Pudlak syndrome. I'd like to close with one other point about oculocutaneous albinism. It's very easy to recognize obvious oculocutaneous albinism. A layperson can do that when they're albino, when they're very white, the hair is white and the skin is pale, and they have these retinal findings. But milder cases of oculocutaneous albinism and X-linked ocular albinism are easily missed. And again, this is something that needs to be on our radar. Here's a girl with nystagmus and low vision. She's had MRI because unable to understand why she has this thing. And when we examine her, she doesn't look like she has oculocutaneous albinism, but if you compare her to her siblings, she's much lighter. And this is the point. There's such a variety of variable expressivity in oculocutaneous albinism. Patients don't always look very pale. And sure enough, when we do iris transilluminations, it's very obvious. But if you don't look for it, you're not going to see it. She underwent all sorts of unnecessary neurological studies because of nystagmus and unexplained reduced vision. Here's a 14-year-old boy with nystagmus and low vision. A similar story, had MRI, neurological evaluation. Nobody could understand what was going on. But when we take a good family history, we see that there are multiple people with nystagmus in the family, and they're all males, and it's X-linked. This is screaming at us, X-linked albinism, ocular albinism. Ocular albinism is X-linked. And there's usually someone in the room who can help us with this diagnosis without even doing any genetic testing. That's the mother. And when we examine the mother, who's asymptomatic, you can see this peripheral modeling in the peripheral retina, which is a carrier sign of X-linked albinism. It shows up a little bit better on the autofluorescence. These streaks, that's classic, this mud splattering, we see this in carriers of X-linked albinism, the mothers. So with that, I'd like to conclude. Genetics, you cannot escape it in pediatric ophthalmology. In the limited time I had, I've gone through 3 scenarios which I feel are important and common enough that we all need to be aware of them. Thank you very much.
Now the floor is open. If we have around 5 minutes. If anybody wants to ask any question, please go ahead.
I have a question to Dr. Arif. Thank you, sir, for the amazing talk. My first question is regarding the aniridia cases that you showed. Is there any age criteria that we should, like, before this age you have to get it done, the genetic analysis, to rule out the
Thank you for the question. Most of the patients, nothing is absolute, but most of the patients will develop it before 5 years old. So if I had a teenager who came in, I would not do it. But it's all statistics. The majority of them will develop it by 5 years old if they have a WT1 mutation. There may be some outliers. But if you have an adult or a teenager, I wouldn't consider it.
And sir, the term that you used, attenuated mucopolysaccharidosis, so is it like it means we missed it, or it is some gene, different kind of
You can think about it that the physiological defect is not severe enough to cause an obvious phenotype, but there are still changes that are subtle that might be passed off as normal. I showed you one extreme case there, that nobody is going to think that that child looked normal. But some patients just have some mild coarse features, and maybe people just think this is a variation in racial features or something. What's the clue going to be? The corneal haze. Sometimes it's not severe. Sometimes it's mild corneal haze. It's not even affecting the vision that much, but it's there.
Okay, and if that adult maid had received some treatment when he was a child, he would have been better off by this age?
It depends on the form. Not all forms have treatment, but yes, definitely.
Thank you, sir.
Thank you. I think we'll close on time. Thank you very much. We hand over to the next session.